Hello everyone, today we will be talking about syncope. What is syncope? It is transient loss of consciousness due to decreased cerebral blood flow. So the person will eventually regain consciousness. Alright. Syncope is divided into three types. The first one is reflex syncope, or it can also be called as neural mediated syncope. The second one is orthostatic syncope, and the third one is cardiac syncope. Let's discuss briefly on the classification of these different types of syncope. And the first one is vasovagal syncope, second one is situational, and the third one is carotid sinus syndrome. If we are talking about the mechanism of action of this reflex syncope, what is this reflex we are talking about? It activates parasympathetic nervous system, which decreases heart rate and causes vasodilation. This vasodilation will lead to hypotension. And because of this decreased heart rate and hypotension, there will be decreased blood pressure, which is decreased cerebral blood flow, which will cause syncope. Let's talk about orthostatic syncope. Orthostatic syncope is further subdivided into three types. Okay. The first one being volume depletion. The second one being autonomic failure. And the third one being drug induced. What is orthostatic syncope? Orthostatic syncope is more than or equal to 20 millimeter mercury drop in systolic blood pressure and more than or equal to 10 millimeter mercury drop in diastolic blood pressure when person stands from supine position, and this occurs within 2 to 5 minutes of standing. It's not like the patient has been standing for approximately 10 minutes and then the syncope occurs. That's not orthostatic. That might come under vasovagal syncope, but not orthostatic. Orthostatic should occur within 5 minutes of standing from supine position, right? Next comes cardiac syncope. Cardiac syncope, if we look at it, it can be broadly classified into two kinds, right? One is arrhythmias. Because of the arrhythmias, patient can have syncope. Okay, these arrhythmias can be bradyarrhythmias or tachyarrhythmias. The second is structural heart defect. For example, there is aortic stenosis, hypertrophic cardiomyopathy, or previous MI which is causing ischemic heart disease, right? So these all can cause structural heart defect, which can lead to cardiac syncope. One thing you should note is these two might have a prodrome, but cardiac syncope doesn't have a prodrome. Right? Now I'll proceed further and let's look at it in the tabular form. So we just talked about it. The reflex syncope can also be called as neural mediated syncope. Right? It activates parasympathetic nervous system. That right? Vasovagal also has like two different names. One is vasodepressor. Vaso means blood vessel, right? Depressor is basically decreases the tone, and it is also called as neurocardiogenic. Let's look at the clues. What are the clues of syncope over here? For the vasovagal syncope, you have a trigger, that is emotional stress. This prolonged standing. For example, you are standing in a bus for more than 10 minutes and suddenly you start feeling the hotness in the body and the sweating and there's nausea. That's the prodrome, which reflex syncope has, and even orthostatic syncope might have it, but you do not see this prodrome in cardiac syncope. Next, let's talk about situational. This situational mostly occurs in pediatric population, right? It occurs with micturition, defecation, swallowing, or coughing. Next comes carotid hypersensitivity. Carotid receptors. It's talking about carotid receptors. Okay, carotid receptors detect increased blood pressure. What happens is when the carotid receptors are very hypersensitive, any pressure on it will detect it as increased blood pressure. So what will this do? it will activate the parasympathetic nervous system, which will cause bradycardia and hypotension. As you can see, stimulation of carotid sinus while standing. So if there is a neck movement or there is mechanical compression, right? So if there's a neck movement, you're tilting your neck here and there and compresses the carotid receptors, then this might cause carotid hypersensitivity. It might detect as increased BP, and then it might activate parasympathetic nervous system. So what are the risk factors for carotid hypersensitivity if we see? Advanced age and carotid atherosclerosis. So you should be careful in these patients. Let's just briefly review the clues, right? So for vasovagal syncope, there is a prodrome. For situational syncope, there is a trigger. What are those triggers? Coughing, micturition, defecation, swallowing, eating. All of these are the triggers, and it usually occurs in the pediatric population. For carotid sinus syndrome, mechanical compression or neck movement. Now let's talk about orthostatic syncope. Orthostatic syncope was caused by three things, right? The first one was volume depletion. So for volume depletion, you should check the volume status. Next comes autonomic failure. Our autonomic nervous system isn't working properly. It might occur due to age, and it might also be seen in diabetes or Parkinson's disease, right? So you should check for the medical history. Next comes drug induced. Look at the drug chart. Why the drug chart? Because vasodilators, alpha blocker, beta blocker, calcium channel blocker, these might cause orthostatic syncope. Next comes cardiac syncope. So it's due to structural defects and arrhythmias. Now if we look at the arrhythmias, they do not appear every time on initial ECG, right? So what do you have to do? You need to do 24-hour Holter ECG monitoring, continuous monitoring, that is. You might notice arrhythmias during the 24 hours, right? Next comes structural heart defects. In this case, you can do an echocardiogram. Let's look at the table. Orthostatic syncope medications like vasodilators, alpha blockers. If we are talking about alpha blockers, it is terazosin, prazosin, doxazosin. Now there are some drugs which have alpha-1 properties, alpha-1 blocking properties. Those include antipsychotics, tricyclic antidepressants, and antihistaminics. These are the drugs which have alpha-1 blocking properties. So next comes antihypertensives, that is ACE inhibitors, ARB, calcium channel blocker, beta blocker, right? Beta blocker, inotrope or chronotrope. And in addition to that, vasodilators also include nitrates, phosphodiesterase 5 inhibitors, hydralazine, all of those stuff. So all these vasodilators and antihypertensive medications and alpha-1 blockers, all of them are among the causes of orthostatic syncope, drug-induced orthostatic syncope. Next, hypovolemic causes, you know it's due to GI losses like vomiting, diarrhea, correct? In addition to that, if you are on a fluid restriction, these might cause hypovolemia. Autonomic dysfunction, we know it's due to advanced age. In addition to that, diabetes and Parkinson also cause autonomic dysfunction. These are the causes of orthostatic syncope. And the cause is unclear because both of them might have a prodrome. What you can do is tilt table testing. It is positive in vasovagal syncope. Next comes cardiac syncope. We told ki cardiac syncope has no prodrome. LVOT obstruction, that is AS and HOCM. Both of them have syncope with exertion, right? Important exertion. Other causes, that is ventricular tachycardia and impairment, they have syncope at rest or supine position. LVOT obstruction will have syncope with exertion, but the remaining two, that is arrhythmias, will have syncope at rest. So if you look at it, this has syncope rest, this have syncope at exertion. Ventricular tachycardia. Conduction impairment is basically bradyarrhythmias. This is tachyarrhythmias. As we had discussed, there are no warning symptoms, cardiomyopathy or ischemic heart disease. And then QT interval prolongation is torsades. Polymorphic is torsades, the point is. So conduction impairment may have preceding fatigue or lightheadedness. ECG abnormalities may be present. This sums up a majority of the points in syncope, right? Let's discuss a little bit about the management of these syncopes. First, vasovagal syncope, you have to reassure them and avoid any triggers. If the patient have recurrent episodes, what do? Then you follow counter pressure techniques. What exactly are counter pressure techniques, if you ask? So the first counter pressure technique he can follow is, after lying in a supine position, he can just raise his legs. Second thing he can do is hand grip, clench his fist and tense his muscle, and this might increase the blood pressure, right? And these counter pressure technique, they abort prodrome. Also, if a person who has a job in high risk setting, right, which is associated with risk of physical injury, the physical injury might be to him or he might be a risk to other people. Let's consider pilots or drivers, commercial drivers. If these people have syncope episodes, then you have to stop their activities, right? Temporary activity restriction. Carotid hypersensitivity, permanent pacemaker may be needed. May be needed, not necessarily, but may be needed for them. And how do you diagnose carotid hypersensitivity? It's by carotid massage. But this carotid massage is avoided in patients with carotid artery stenosis. Why? Because it might cause increased risk of thromboembolism and stroke. Now let's look at the management in orthostatic syncope. Alright, the first thing you have to do here is posture modification. Patient is rising fast from a sitting position or lying position, that is from supine position, then you have to ask him to rise slowly when he is trying to stand. Okay, first thing is posture modification. Second thing is, if it's due to medications, right, so you have to decrease the dose, discontinue the medication if it's possible. If there is an alternative that you can use instead of this medication, then it's better to discontinue that medication. Next is, you have to increase the fluid status. So increase fluid, and salt also you can take. Salt will hold the fluid and water in the body. That's how you can correct the hypovolemia. Cardiac syncope, we all know, is due to no prodrome period. It can occur at rest or supine position. These are the most important points, and it is sudden onset. Recovery is also very quick. Ask why it's sudden onset and why there is no prodrome. The answer is, there is tachycardia, there is problem in ventricular filling, and this causes abrupt and extreme drop in cardiac output, and this will lead to syncope. So these dropped QRS complexes are dropped beats or ectopics. Take you to my notes, which are very messy. I've discussed most of the points over here: vasovagal syncope, trigger, prodrome, situational occurs with all these things, carotid hypersensitivity we have discussed, right? Management also we have discussed. Orthostatic we have discussed majority of the points, right? Yes, the point which we did not discuss is the differential diagnosis in orthostatic syncope. It might be due to cardiac conduction abnormalities, carotid hypersensitivity, right? Cardiac syncope also we have discussed. sudden onset, lack of prodrome, at rest and seated, underlying structural diseases like prior MI or MR murmur, frequent ectopic beats. We have discussed all of it. The thing we have not discussed over here is the diagnosis can be confirmed by carotid massage, right? Carotid hypersensitivity diagnosis can be confirmed by carotid massage, often aided by tilt table to ensure the patient is secured and doesn't fall. If you know all these points, it's more than enough. Another thing that you have to know about is how to differentiate between syncope and seizures. First thing the seizure has is aura, and a syncope has is prodrome. Prodrome is the inner warmth and sweating and nausea that you feel before having a loss of consciousness attack. Aura is basically the olfactory smell or visual disturbances that a person might feel before having a seizure. And seizure can occur at any position. Syncope often occurs during standing, that is vasovagal. And if we are talking about any position, then we can discuss a cardiac syncope. Tongue biting is more specific for a seizure, right? And it's often lateral. Now, if in some rare cases, tongue biting can occur in syncope also. We look at the tongue bite, it's usually in the frontal part of the tongue. In seizure, it's in the lateral part. Let's talk about the convulsive movements. They are common in seizures, right? But it can also occur in syncope. And when does this happen? In seizures, there's abnormal electrical activity in the brain, right? This will cause convulsive movements. And this starts before or it is during the loss of consciousness period. Whereas in syncope, the convulsive movements, that is clonic jerks, can occur after loss of consciousness, and these convulsive jerks are due to hypoperfusion. Hypoperfusion in brain will cause hypoxia, and this hypoxia will lead to clonic movements in the body. Urinary incontinence is also more common with seizures, and in syncope, if it does occur, it occurs after the patient has lost his consciousness. Post-recovery period is variable for a seizure, but then for a syncope, it's very fast and there's no residual deficit. Like in 2 to 3 minutes, the patient gets up on his own and there's no confusion, but in seizure, there is a confusion. For seizure, the trigger can be lack of sleep, flashing light, emotional stress, alcohol withdrawal, and idiopathic. For vasovagal syncope, prolonged standing, physical or emotional stress, and heat. These may precipitate vasovagal syncope, whereas lack of sleep, flashing lights, emotional stress, alcohol withdrawal, and idiopathic causes can precipitate a seizure. That's all we have to discuss for syncope.